Welcome to our Donor's Anatomic Record Project. My name is Logan Kinamore of Tank 28.
I'm Olivia Gilbert.
I'm Meredith Gioe.
And I'm Zorrilla.
So today we are going to explore some of the anatomical variation and pathophysiology that we found in our cadaver during dissection and postulate what the potential causes of death might be. So our cadaver was 92 years old at her age of death. She was assigned female at birth. She was a Caucasian woman. Her occupation was listed on the death certificate as teacher's aide, and cause of death was indicated as cerebrovascular accident.
All right, so we're going to talk a little bit about the anatomic variation that we found upon dissection last semester. The first being a high origin of the radial artery, and the second being an aberrant obturator artery. So most branching of the brachial artery into the radial and ulnar arteries occurs in the cubital fossa. And in our cadaver, we had a high origin of both radial arteries occurring in the upper third of the arm. The incidence of this anatomical variation ranges from 3 to 15%. And as you can see in this example, the brachial artery is branching into the radial artery very proximally to the cubital fossa here. And this anatomic variation has no pathophysiological consequences. The second anatomical variation that we found throughout dissection was an aberrant obturator artery on the left side. So normally the obturator artery is a branch off of the anterior division of the internal iliac artery, and our cadaver had an obturator artery that branched off of the external iliac artery. Now this anatomic variation is very common and is reported to be up to 20% of the population, and you can see right here that it is this aberrant obturator artery is branching off of the external iliac artery, and this is the internal iliac artery. And the obturator artery is going through the obturator foramen.
Now we're going to discuss some of our findings in regards to respiratory pathology. On microscopic examination of her lung tissue, we found evidence for emphysema. So as you can see on the right, here the alveoli are fairly evenly distributed. There are very nice impact alveolar septae on the left rather. On the right is our cadaver sample, and here you can see that the alveoli are very disrupted, disjointed, and distended. So pathophysiology of edema is characterized by decreased pulmonary elastic recoil. This is an obstructive pulmonary disease, meaning that the increased compliance of the lungs leads to air trapping upon expiration. And the alveoli and the alveolar septae are slowly descended and disintegrated. Treatments for emphysema include pharmacotherapy, which is inhaled steroids, bronchodilators, and antibiotics for recurrent infections, which are often found in people with emphysema. Surgical treatment includes lung volume reduction, where small sections of lung are resected, small sections of highly diseased tissue, and or full lung transplant for severe cases. Supplemental oxygen is often given to patients with emphysema to increase their blood oxygen content, and respiratory therapists may teach breathing exercises to emphysema patients to maximize their respiratory efficiency and to keep respiratory muscles functioning. And being that smoking is one of the largest predisposing risk factors to emphysema, smoking cessation is highly encouraged in people who have emphysema.
All right, now we're going to talk about some neuropathology. So our patient had evidence of cerebral edema. In other organs of the body, this is attributed to an accumulation of fluid in the extracellular space, but in the brain, it's caused by the swelling of glial processes, and so you can see here these pale cytoplasmic patches. And we believe her cerebral edema was caused by an occlusion of the left middle cerebral artery, so this ischemic event. We were actually able to see and dissect this embolism in the lab. And this also caused some increased intracranial pressure as seen by the different herniations that she had. And with regard to treatment, this can include anywhere from decompressive craniectomy or osmotherapy in efforts to decrease the intracranial pressure. if the cerebral edema did not cause her death, which it does in 80% of patients who have this acute ischemic stroke.
Now we're going to talk a little bit about the cardiac pathology we found within our patient. And she had quite a bit of coronary artery disease, and we saw some evidence both histologically as well as anatomically with 100% occlusion of the posterior interventricular artery. We also saw quite a bit of evidence of atherosclerosis within the right coronary artery, and we could see this based on the firmness of that artery as well as the small diameter of the artery, which would decrease blood flow to the heart. We also saw evidence when we sectioned the heart of a cor pulmonale with quite a bit of right ventricular hypertrophy, and you can see in this image to the right an example of what right ventricular hypertrophy looks like. And we also saw, we believe this is due to evidence of tumors that we saw within the lung, which can cause pulmonary hypertension, which can lead to the cor pulmonale. And then some treatment options with more mild versions of coronary artery disease. The first thing we really want to do is try to prevent worsening of the condition with lifestyle changes. And some of this includes exercise, changes in diet, as well as if the patient is a smoker, decreasing in the amount of smoke. And if that doesn't work, we want to lead to some medications, including beta blockers and calcium channel blockers, which are going to decrease the work that the heart has to produce, as well as statins and anticoagulants. And then with more severe cases of coronary artery disease, it's essential to have some surgical intervention, including stents of the coronary arteries in order to increase the diameter, as well as the blood flow to the heart, and then a coronary artery bypass graft in order to bypass the occluded site in order to supply the heart with blood.
All right, lastly, we're going to talk about some nephropathology. So our patient had some signs of nephrosclerosis, which we believe is most likely caused by chronic hypertension. This led to the loss of renal function due to the damage of the glomerular endothelial lining. And in 28% of patients, this can lead to end-stage renal disease. So with the treatment for her nephrosclerosis, we think that an antihypertensive medication would have not only helped to preserve her renal function, but would have also helped to prevent some of the cardiac and pulmonary system pathology that she had.
So in summary, we believe the major contributor to the pathologies that we found upon our dissection was just due to age. Our cadaver was 92 years old, and it is known that increased age is associated with pathologies such as emphysema and atherosclerosis and hypertension. But also we wanted to say that possible factors that could have contributed to the pathology that we found were the presence of hypertension contributing to her nephrosclerosis and coronary artery disease, but also she had hyperlipidemia or hypercholesterolemia that could have caused coronary artery disease. And then due to the lack of a smoker's lung appearance on her gross examination, we believe that it was exposure to air pollutants and or city living that could have been the primary cause of her emphysema. And so ultimately, we deduced that her primary cause of death was probably a myocardial infarction, and that is due to the presence of 100% occlusion in her posterior interventricular artery. And then we believe that secondarily, she had a cerebrovascular accident, which we did find upon our dissection with a thrombus in the middle cerebral artery and the edema found in her brain tissue. And this is a list of all the references we used to put together this presentation, and we thank you so much for listening to us.